So obviously how useful this would be depends on the setting that you are working in. If you're fully employed by a team and you're at every training session and every match, you have no need for this. You can do your recording of injuries in a much simpler way. But for example, in my role, I'm also the chief medical officer at the Norwegian Olympic Training Center. So I'm responsible for the healthcare and for risk management, if you like, for all candidate athletes now preparing for the Rio Olympic Games. And all these athletes have to, every Sunday, report their injuries during the past week, and that information goes directly to the medical team of each of the teams. And that's something we have never been able to do in the past, because the problem, as Grete pointed out, is that these athletes are all over the world at any given time, and very rarely do we have a doctor or a physical therapist traveling with them to training camps or to competitions, except for the big teams, if you like. All right, so the next topic now is the next step here, or the third step actually in the model I started to introduce to you, and that relates to screening examinations or periodic health examinations. That was the original title. I've changed that title somewhat. So the title now of this talk is Why Risk Factor Screening Will Not Help You Identify the Athlete Who Will Become Injured. And you'll understand why I changed my title like this as I move forward. Now I showed you the slide already, with the two main purposes here relate to: one, finding out if they're sick now, two, or injured now, and two, whether it's possible to identify who will become injured or ill as we move into the future. And the first part, so this is a major benefit of doing periodic health examinations, relates to: are they healthy or not? And data that Arnhild Bakken, who works here at Aspetar, you want to raise your hand, Arnhild, wave to the crowd there, doing a massive job with the rest of the team to collect all the data from this comprehensive screening that I described to you earlier. And you can see here that if you do extensive examinations, in this case on 317 professional football players, you will find a whole host of problems that they have. Just look at these numbers. 95% have a medical screening, or a problem related to medical screening. Now, a lot of that is vitamin D deficiency, all right? But still, you find a lot of problems that way. 30 or 10% of them had identified a problem through cardiac screening. That doesn't mean that all 30 are going to die. It's just that we found something on the cardiac screening of consequence. And the musculoskeletal screening, 1 in 3 have an identified problem here. So yes, screening is helpful because we are finding out a host of problems that we can deal with and make a plan to deal with as we move forward. But this is the reason why a lot of people say we do screening. We do screening because we can identify risk, or we can identify players with increased risk. And that is what I'm going to be talking about, because the question is, can we do that? Can we identify the player at risk? This is what we ideally would like to see if we want to develop a screening test. So the principle is like this. So this would be a low score on the screening test over here. This would be a high score on the screening test over here. And this would be the number of athletes with that particular score. And this you recognize as a normal distribution pattern. And here it looks like we have a second population over here. And in an ideal world, we would like a test that is such that all the players who stay healthy are here, and all the players who end up with injury are over here. That would be the perfect screening test, wouldn't it? You wonder, will they get a shoulder problem? You do this test. All the ones who turn out to get an injury will be over here, and all the ones who turn out to be healthy have a score lower than this magic value here. This would also be okay, wouldn't it? Not too discrete population, but at least such that the ones who get injured are at this end, and the ones who don't get injured are at this end, because they can be separated then by this cutoff value where you say, well, if you're over this value, you need some sort of intervention because your injury risk is very, very high. Follow that, right? So let me use one example. And those of you working in female handball, at least, are familiar, I'm sure, with this type of a screening test where you have somebody jump down from a box, and you see a player jumping up here with good control. If I can just get this mouse working, there we go. And then on your right, sorry, you will see a player with bad control. And the assumption is that players that display this type of valgus or knock-knee position in landing and cutting and so on have much greater risk for suffering an ACL injury than a player who jumps with good control like this over on this side. Right? How many agree with this? Raise your hand, please. A lot of hands. Thank you very much. That's the assumption. And where does this come from? Well, this comes from a study that was published in 2005 by a good friend, Tim Hewitt, and his co-workers, where it looked like this test had revealed this particular trait. So athletes who injured themselves with ACL injuries had 8 degrees greater knee abduction angle. So that's what we see as valgus when we see the test. And if you have a more advanced system, you can measure knee abduction moment, which they did in the lab, 2.5 times greater. Higher ground reaction forces, they landed more stiffly when they landed, like we just saw. And they calculated that this test could predict ACL injuries with a 73% specificity and a 78% sensitivity. That sounds great, doesn't it? And this is why this type of testing has been advocated. So how many lectures, Grete, have you given where you said this is what you should be doing? 100. So she's given 100 lectures saying this is good. We should be doing this, all right? So let's look at the data. So this is knee abduction angle here. And you see the dots. That's all the 205 subjects. And you see the X's. They're the ones who got injured. So they're all here over on the high side, right? We can agree on that. But even more sensitive, they say, is knee abduction moment. And you see again that knee abduction moment, they're over here. Here's one with a very extreme value out here on the side. So what I've done is I've transformed these data. So simply just counting the number with each value along this axis. So we're back to the figure I just showed you. So low values here, high values here. And this is, so there are 5 athletes with this value, 2 with this value, 4 with this value, a whole bunch with this value, and some out here. All right, follow me? So this is almost normally distributed. Not quite, it's a little bit skewed towards the higher, but it doesn't matter. There's almost a normal distribution here. And these red dots represent the injuries. Can you see them? No, you can't. So I made them bigger. Now you can see them. Isn't that nice? So where are they here? Are they all the way out there on the side, all of them? No. Do we have 2 distinctly separate populations? No. So where do we draw the line then and say if you're over this value, you have increased risk? If we draw the line there, we'll say 3 athletes have increased risk. 1 of them went on to have an ACL injury. But we missed the majority of ACL injuries. So let's move it. So where do we move it? Let's move it here. If we move it there, we capture half of the injuries, but only half of the injuries. So to get all of the injuries, or 90% of the injuries, we have to move it all the way over there. But by doing that, we've also declared that half of the athletes have increased risk. So does this really help us then in identifying who's at risk? If you get a certain score for a certain player, are you prepared to say, you're at increased risk, you need a special program, you're okay, you don't need a special program? Probably not. So maybe it's not such a strong risk factor for injury anyway. Let's try a really strong risk factor for injury. So what is the strongest risk factor for injury? Some would say the coach. At least Manchester United fans would say that it's the coach. But you're absolutely right. The most consistent risk factor for injury is a history of a same injury, a previous injury. And this is just an example for hamstring strains. So data from Iceland by chance. But what this shows is that the odds ratio, if you have a history of a hamstring strain, your odds are 7 times greater. So that's a very impressive odds ratio. Do you know what the odds ratio for getting lung cancer if you're a smoker is? Compared to someone who doesn't smoke? Or a cardiac arrest if you're a smoker? Anyone has any idea? We're talking about odds ratios all the time. 2, 1.7, 1.8, so in that region. And we're thinking that's a really, really strong risk factor, right? This is 7, so that's a huge risk factor. It's like the worst you see in the history of medicine is previous injury as a risk factor for new injury. So that should be the perfect separator then, shouldn't it? So look at the data from that study. And again, I've depicted that. This is the actual data from the study. So on the left, you have the guys who said, oh, this should be the way around. No, I've not had a previous injury. And this is, yes, I've had a previous injury. And these are the ones, again, who had an injury. So in that group, there were 10. In that group, there were 9. So even using this strongest risk factor that we have to separate in 2, with an odds ratio of 7, that means 7 times greater chance of getting an injury if you belong to this group over here, right? Than if you belong to this group over here. Yet, if we use that as the separator, we only capture half the people who get injured. So yes, the risk is higher, but we miss half the injured population if we were to use this as our tool to say, you guys need a special program, you guys don't. Because that's really what we're doing with screening, isn't it? We're saying, you guys need a program, you guys don't. That's pretty depressive, isn't it? So Grete, you have been giving a lecture 100 times, teaching people something that clearly doesn't work. And we all walk around believing that what we're doing by saying, oh, your valgus angle isn't quite right, that's important. But of course she's right. We know that valgus is a risk factor, so if you see somebody jumping and landing like that, you should by all means do something to them to try to rectify that problem. But my point is you should be doing it to all the others as well. So everybody should be doing the program. Then we know that we can affect injury rates. That's the solution. So, finalizing this section of the talk, this is what's in the IOC statement of the purposes of screening. I'd like to add a few points in blue here, and the ones that are underlined are the ones that I think are the main reasons why we should be screening or doing periodic health examinations. 1, once a year at least, stop and have a good look at the athlete and say, okay, what are your problems? Find those problems so we can do something about it. It's about the management of established disease or established injuries more than it is about predicting risk for the future. And secondly, I find that that conversation and that test is very helpful in establishing trust as a physician with my athletes. Sometimes it's a new player, it's the first time I meet. It's a fantastic opportunity to establish that relationship while they are not injured, because that's the relationship you're going to need the day that they are.